Okay guys, we're gonna continue about the video about how can you expect the person is going in preterm labor. Again, remember the number 37 less than week. We call it preterm labor, right? We know the cause, maybe urinary tract infection, can be problem in anatomical problem, it can be PID, what is known as PID in pregnancy, chorionitis. We can be having idiopathic cause as well. We can be having a biconic uterus, unicorn uterus, right? All anatomical malformation. And also if we're having a very big baby, twin pregnancy, polyhydramnios, that is more amount of liquor, more amount of water, you can say in like simple language. So that will cause us to have a preterm labor, right? Now how we can expect the patient that is going in preterm labor, right? Remember, if we are doing a nasal bone scan, okay, or neutral thickness, this is very important in order to detect Down syndrome. What is this thickness? This is the thickness behind your neck, that is known as the nape of the neck, right? Just below the hairline and in the cervical area, that is the thickness of the neck. Very important is the length of cervix. If it is less than 2.5 centimeters, right, very high chance that it will be going in preterm labor. Along with this, the shape of the cervix is very important. Now just to give you an idea, okay, all right, so imagine this is the uterus. Now imagine this is the uterus, right? So if I draw the uterus, one second. Okay, so this is a uterus, right? Okay, so if I draw a line, right, if I draw a line, I'm able to see somewhat this structure. It's been sticking, so this is T, right? This T is absolutely normal. This is normal. Okay, now let us try to see another state where the uterus is relatively kind of opening up. Okay, in this case we will be able to somewhat like this. Is that right? Can you guys make it out? Right, so this is Y. Okay, this is the beginning. Okay, now then we have the intermediate state. Okay, in this state we are kind of relatively able to see kind of V shape, V shape. Okay, and the final one, the worst of the worst, what happens in this is also the bag of membrane also comes out, right? So this is the baby, the bag of also comes out, so it becomes U shape. So this is the final problem. So this is how also you can identify by the help of the shape of the cervix. Okay, so one second. Okay, so we have another technique we can know. So whenever you see the uterus, right, let's say this is the amniotic sac here, right? Here is the baby, right? So this amniotic sac is sticking to the wall of the uterine cavity. Okay, imagine it is like a glue, it's like a magnet. So this is sticking to the wall of the uterine cavity. It is by fetal fibronectin. Okay, this is very important. Now if this fetal fibronectin we are able to see in the secretion, that means yes, this premature separation is happening, right? But remember, if you see it before 22 week of gestation, okay, and after 37 week of gestation, that is normal, right? Other than this is pathological. If you see it is pathological, then you can remember either it is preterm labor, or premature rupture of membrane. Okay, this is very important, right? So now we want to know then how can we stop this preterm labor. We want to stop this preterm labor, right? Because we want to give enough time for the baby to grow, enough time. If it is around 32 weeks of gestation, we want to immediately give these steroids in order to make the lungs become mature, right? So we are giving these tocolytics in order to buy us some time to give the body for the steroid to have enough time to work, right? So we do not want preterm labor to be occurring in the first place. So what are the tocolytics? What are the tocolytics that we can use? Okay, all right. So remember, whenever we're talking about tocolytics, we can say beta agonist like salbutamol, tibutylin, iso subprime, right? But remember, we are having a side effect here. We are having pulmonary edema, or we are having tachycardia. Okay, that is very important here. Now we are also having calcium channel blockers. Remember, we are having calcium channel blockers. This is the drug of choice. Here is nifedipine. Very good. This is nifedipine. Okay, and we also have calcium antagonist. If you're giving calcium antagonist, obviously we're not allowing the contraction to take place. What is this? Magnesium sulfate, right? This is actually a very good drug, because obviously it is helping in tocolytics to stop the contraction, and also it is known as the neuroprotective drug. It is neuroprotective drug, and also it reduces the incidence of having cerebral palsy of the baby, okay, and not the mother, of the mother, not the mother, sorry, oh my god, of the baby, right? But again, all the good things will have some bad things, and all the bad things will have some good things, right? The side effect of this magnesium sulfate is hypotonia of baby. This is one thing you have to remember, hypotonia of the baby. But the best one, nifedipine, also very good, is magnesium sulfate, right? And also you can give sometimes prostaglandin synthesis inhibitors, right? Prostaglandin synthesis inhibitors. We are not allowing the prostaglandin to be produced in the first place, right? What we can give is indomethacin. Okay, we can give around like 75 mg one dose per day, or you can give in the dose of 25 mg 5 times per day. Is that right? Okay, now the another thing you have to remember, we also have the safest drug, the safest, if you want to know the safest, safety is highest is in progesterone. The word itself says, what is progesterone? Pro, gestation, hormone, the hormone that is responsible to maintain the gestation. Progesterone is the safest drug, right? Safest drug, right? And we also have nitroglycerin patch, but remember, this progesterone is mostly given as a profile access. If we see the mother is having high chance of preterm labor, that time we will be giving progesterone as a profile access. It is not so effective as if it is used as a treatment. Okay, so this is the short video about tocolytics. And remember, tocolytics we are giving only to buy us time in order to give a steroid, and that steroid has enough time to work and produce the benefits, that is make these surfactants so that the lung is matured, Okay, and remember, with the tocolytics, the maximum that you can go, the maximum you can prolong the labor, maximum. It's not that you give tocolytics and you can prevent the labor for 1 month. Maximum is 7 days, but ideally we need just 2 days for the steroid to do the action. Okay, that was a small video about this. We will see in the next video, upcoming video, third stage of labor.